بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على سيدنا محمد عليه أفضل الصلاة والتسليم، معلمنا وقدوتنا وحبيبنا صلى الله عليه وسلم. اليوم سيتم استكمال موضوع الهايبوناتريميا clinical approach or practical approach. Today we'll discuss in details, and I hope you have time to finish with me this presentation today. I will summarize as I can. Okay. توكلنا على الله. بسم الله الرحمن الرحيم. المرة اللي فاتت بدأنا بالالكوليزم ده بتاع الهايبوكاليميا. The special for Dr. Kamil. This classification of hypokalemia. When you have one patient with hypokalemia, we start the first step to check his urine potassium divided by urine creatinine, and I will start our differential diagnosis for my patient according to the urine potassium and the urine creatinine. Before this step, we decide if your patient, you saw any consult with hypokalemia, at first this patient is emergency or not. We decide any patient with hypokalemia should do ECG, and you should rule out any cardiac arrhythmia. And when you examine your patient, you check your patient is paralyzed or no. The first step in management any hypokalemia patient is emergency or not. If emergency, please treat and then go to this algorithm to diagnose your patient later. Okay, if I have urine potassium to urine creatinine is less than 2, I am this side, maybe shift, maybe with some caveats, diarrhea or remote diuretic use or other causes. We already discussed this in the last presentation. If I have my urine potassium to urine creatinine less than 2, second step, just check acid-base disorders. If no acid-base disorders, this means with acute shift potassium into cells. We discussed already this in details in the last presentation. Sometimes if you do acid-base disturbance and you will find some metabolic acidosis or metabolic alkalosis, acid-base disturbance. If acidosis, just think maybe your patient have diarrhea. If it's no alkalosis, may your patient go to this categories, patient with chronic salt washing diarrhea or chronic salt wasting, chloride salt wasting, long time, chronic patient, genetic problem, or this patient with skin with cystic fibrosis or other remote use of diuretics is the most common for this metabolic alkalosis with urine potassium to creatinine less than 2. Today we'll discuss this urine potassium to creatinine spot sample. We found this more than 2. Second step, as we mentioned, they should check metabolic acid-base disorders. If I found my patient metabolic acidosis, I will go to this diagram, either diarrhea, distal RTA, proximal RTA, carbonic anhydrase inhibitors. We'll go to this diagram. If my patient with metabolic alkalosis, I will go to this diagram and then will assess his blood pressure, hypertension or no, or extra effective arterial blood volume is low or high. If my patient is low or normal blood pressure, I will go to check urine chloride, and this urine chloride will divide my patient either low with vomiting, either persistence high urine chloride with Barter Channels syndrome. If it's intermittent high-low, this was diuretic here. If it's my patient with metabolic alkalosis and hypertension and his blood pressure high, we'll go to this category with condition associated with primary high mineralocorticoid effect, either primary hyperaldosterone with hyperrenin or cortisol act as aldosterone, or mutation in our innate channels, this with Liddle syndrome. And we'll come to differentiate this in details and by diagrams, and I hope this diagram to be easy and summarize all previous diagram before. Okay, just we'll go to potassium loss. Today, potassium loss means we have here, if urine potassium to creatinine less than 2, this was shift. If it's more than 2 with loss, and this with loss will go to acid-base disturbance, either acidosis or alkalosis. We'll start to rule this first, and after that we'll go to this and this. Okay. Potassium loss. we'll check acid-base disorder. We have already hypokalemia and urine potassium to create ratio more than 2. I will check my acid-base disorders. In differential diagnosis, we need patient with hypokalemia and hypercholoremic metabolic acidosis. We have 3 differential diagnoses for this. Either this patient with diarrhea, either this patient with distal RTA, either this patient received carbonic anhydrase inhibitors like acetazolamide and topiramate. Topiramate, this patient already medication used in epilepsy or seizure by neurology. Now, hypokalemia with hypercholoremic high chloride and metabolic acidosis with hypokalemia, diarrhea, distal RTA, carbonic anhydrase inhibitor, you should rule these drugs. Otherwise, with no diarrhea, will be used distal RTA. As we mentioned here, hypercholoremic metabolic acidosis, we have diarrhea, distal RTA, or proximal RTA, carbonic anhydrase is the most common cause you should search. We have case 30 years old female, spaced out, خارج النطاق, and she's weak. No history of previous similar episodes, no history of diarrhea, no diarrhea. Her blood pressure is low, a little bit low normal, 100/70, with heart rate tachycardia, and regular heart rate with GVV is flat, jugular venous pressure. When you examine a flat, not distended, and generalized weakness with no focal neurological deficit. We are did already EPG for her, pH 7, bicarb is 8, and the BCO2 is 30. pH is low, bicarb is low, and BCO2 is 30. This was metabolic acidosis, not fully compensated. I think it was respiratory combined with respiratory acidosis too. The acid-base disorders, we have multiple choices. If there is a question for this patient metabolic acidosis only, or metabolic acidosis with respiratory alkalosis, or metabolic acidosis with respiratory acidosis, or respiratory. Our patient here, his answer is C, metabolic acidosis with respiratory acidosis. And with it, sodium 130, potassium is low, 2.1, bicarb is 8, and the chloride is high. And the anion gap is 11 is normal. Our normal anion gap 12 minus or plus 2. And the serum albumin, I think, is 30. This is a little bit low, and the corrected anion gap will be more low. Each 10 gram decrease in albumin, you should decrease the anion gap by 2. Plasma potassium here, hypokalemic 2.1. Any consult for any hypokalemia with 2.1, this emergence or no? ECG is normal or no? Your patient from muscle weakness, paralysis, quadriplegia, respiratory muscle failure is emergence or not? The first step, treat your patient first, give KCL, whatever the amount, and then investigate the cause. If emergence or no, you will look for the ECG and you will see here. As we said, emergency is cardiac arrhythmia is the most important, and respiratory muscle weakness and respiratory paralysis and respiratory failure. Second question, because of severe acidemia, your initial treatment for this patient, I will give 1 amp sodium bicarb. I will give 2 amp sodium bicarb with half normal saline. I will give 3 amp 150, each amp 50 millimole sodium bicarb in 1 liter D5 water by rate at 250 cc per hour, or you will not get bicarb. If you will get bicarb with this hypokalemia, you will increase more shift. This is a big mistake. Take care from this point. If I treat this patient for acidosis now, you will do more shift to potassium intracellular, and the more hypokalemia, and the patient will go to cardiac arrhythmia and arrest, or respiratory muscle failure and arrest, either cardiac or respiratory arrest. So the best answer for this, please give potassium chloride first. No sodium bicarb first. Your answer, you will not give any sodium bicarb for this patient. I will treat his hypokalemia first. Okay, this is our answer already. I will not give any sodium bicarb in any patient with severe metabolic acidosis and hypokalemia. I will give only potassium chloride first line of management. And don't forget for this, don't give D5 water with potassium chloride, because if you will give D5 water, this will stimulate insulin, this will activate our sodium ATPase channel and skeletal and hepatic muscles, and this will increase more potassium shift intracellular to D5 water, sodium bicarb, contraindicated. The first line management in the patient with hypokalemia. First line of your treatment is KCL. Our patient already with hyperchloremic, we have chloride is high, is 111 millimole, with metabolic acidosis and hypokalemia, and the urine pH down for this patient more than 5.5 is 6. This patient with distal RTA. What is the most likely diagnosis? Already we are diagnosis for this patient as the criteria mentioned, distal RTA. Distal RTA means ammonium defect. Ammonium defect, low ammonium excretion disease. Distal RTA, low ammonium excretion disease. This distal RTA, the syndrome. This type 1 distal RTA syndrome with normal ungated metabolic acidosis reduced the urinary ammonium excretion due to impaired collecting duct. Impaired collecting duct hydrogen secretion. We have problem in collecting duct to excrete our hydrogen, our acid, associated with hypokalemia, calcium phosphate kidney stones, and nephrocalcinosis. The most common stones with distal RTA is calcium phosphate kidney stones, and your patient characterized if you have X-ray and exam and the patient hypokalemia, metabolic acidosis, abdominal X-ray with nephrocalcinosis, you just think on this. Hypokalemia resolve when metabolic acidosis is corrected, okay? But our management first step to correct the hypokalemia. What is the cause of this distal RTA? As an inherited basolateral chloride bicarb ion exchanger or hydrogen ATPase problem mutation already, or acquired like Sjogren syndrome, systemic lupus, rheumatoid arthritis, hypercalciuric disorder, primary hyperthyroidism, sarcoidosis, idiopathic, this all causes of distal RTA. You can read. Why hypokalemia with distal RTA? Is the diagram or algorithm for hypokalemia with distal RTA from increased intracellular acidosis, and this lead to decrease sodium potassium ATPase and stimulated proximal convoluted tubule chloride reabsorption. All this decrease upstreams of sodium reabsorption and lead to urinary loss of sodium, hypovolemia, and this will end even by decreased bicarb, decrease filter bicarb. At the end, all this lead to sodium and decreased sodium reabsorption and more sodium loss, and at the end will end by this hypovolemia and high aldosterone. Aldosterone at the end will increase potassium secretion and more potassium, more urinary potassium loss. And this genetic failure of aldosterone sensitive distal nephron hydrogen secretion. Bicarb is present in aldosterone sensitive distal nephron, lemon, and all this lead to more potassium secretion. And I will discuss this by pictures later to be easy. RTA means recognize the ammonium defect. This is the definition of RTA. We have ammonium defect. You should recognize it. We have ammonium, normal ammonium excretion around 40 millimole per day. 40 millimole per day is our ammonium excretion and urine. It's difficult or technically or not every center can measure it. Just we can guess it. And forget urine pH. Urine pH not accurate to detect your ammonium excretion in urine. Just will guess by urine osmolar gap, not pH or urine gap. Now not used, only now urine osmolar gap. What is osmolar gap is the difference between the measured and the calculated, whatever. Osmolar gap in the serum or the urine, this is the difference between measured already by labs and what is your calculation. The difference between will give you this ammonium. You will guess for amount of ammonia. We have measured by lab minus calculated. I will calculate sodium, potassium in urine, and then we will multiply by 2 because this anion. I will multiply 2. It compensates this anion, just sodium, potassium, multiply by 2 plus urea plus glucose in urine. All this will give you this ammonium plus anion. If now, again, measured by lab minus sodium, potassium multiplied by 2 plus urea plus glucose, it will give you the amount of ammonia. And we have here for our patient urine osmolarity by lab already around 200, and minus this is sodium, potassium multiplied by 2 and plus urea plus glucose, and it will give you high. Our normal ammonium around 40 millimole per day. Now this patient 130. This 130 will come now this high ammonium excretion. We have two differential diagnosis now. If it's ammonium excretion in patient with hypercholoremic metabolic acidosis with ammonium excretion is high. If it's not high, this with RTA. Now finish with RTA if not high. If it's yes, what is anion? We'll check the chloride. If the chloride, the GIT loss, this GIT bicarbonate, so check urine chloride. If it's low, this was GIT loss. If it's other, you will check for other anions. What is other anions? Just to put in your mind. If we have any other anions, this will combine with acidosis and will end by loss ammonium with anions, and will take all this will take sodium and potassium in urine. Yes, I think this is difficult. Just if we have unknown or other anions, will combine with bicarb or with acidosis or hydrogen, and this will end by excretion more ammoniums, or this glutamine already will go to bicarb and ammonium, and this anions will combine this acidosis or hydrogen and will end by ammonium excretion and anion. This will accompany sodium and potassium secretion and will lead to hypokalemia at the end. Can you sniff anions? Like patient taking toluene and hippuric acid, this anion filtered and secreted, and this anion when you are taking sodium and potassium and lead to hypokalemia with hypercholoremic metabolic acidosis with no diarrhea, and this patient with high ammonium excretion, just these anions, this make it just combine with acidosis, excrete more ammonium, with taking with here sodium, potassium will take with here, lead to at the end of hypokalemia. You should think in this two diagnosis, toluene and hippuric sniff. As we know, this diagram just to show what is pathway of toluene. Toluene is already taken by liver, benzoic acid and glycine, and by the cascade, hippuric acid at the end will go to be excreted via kidneys. Hippuric acid will take hippurate will take sodium and the potassium with so ammonium excretion. All this will lead to hypokalemia at the end. By this toluene will end by pathway of metabolism via liver and will excrete it via kidney as a hippurate with sodium and the potassium and the ammonium, and will end by hypokalemia. The same mechanism will be happening with diabetic ketosis, patient with fatty acid, and will end by beta hydroxybutyrate and will excrete it as the same issue. Will take sodium and potassium, and ammonium excretion will lead to hypokalemia in patient with diabetic ketoacidosis. Now, high anion gap, hypercholoremic metabolic acidosis. Just checks ammonium excretion. If it's not high, this is RTA. If it's yes, it's high. What is anion? We'll check urine chloride. If it's low, this was diarrhea or GIT loss. Otherwise, we'll just don't forget this hippurate or keto acid ions. Now we have this our algorithm for hypokalemia less than 3.5, urine potassium to creatinine less than 2 with shift, more than 2 with loss. The first issue, acid-base disorders, this metabolic acidosis or metabolic alkalosis. If metabolic acidosis, diarrhea, distal RTA, proximal RTA, with large dose of sodium bicarb, carbonic anhydrase inhibitor, acetazolamide, topiramate, overproduction of acid with high rate of secretion of its anion with potassium in urine. This is our toluene hippurate or hippuric acid. And another issue, urethral diversion procedure. Now we finish this side, and we'll give you a case example for that. I will go, what is acid-base disturbance, metabolic alkalosis? If I have hypokalemia, urine potassium create more than 2 acid-base disorders, metabolic alkalosis. Case number 6, 22 years woman with recurrent episode of symptomatic hypokalemia. No medication, no vomiting, no diarrhea. This is a special case, not related to our, I will discuss the diagnosis at the end. 22, and the female with a recurrent episode of hypokalemia. This is a good case, just I like to put in your mind. In a young female with recurrent hypokalemia, no medication, she denies this history of vomiting or diarrhea and the diuretic. She denies all this, or laxative abuse. And her body weight 45, he decreased from 60 around maybe 10 years back. She's a university student. She's a student with no psychiatric problem. Please concentrate in this patient because this is the most common case we'll see in young women, female, with recurrent hypokalemia. She denied vomiting, diarrhea, diuretic, laxative abuse, body weight decreased from 45 to 60, from 45 from 60 before, and she's a student with no psychiatric problem. When I examine this woman, this is healthy, slim, she's too thin, and she's fully conscious oriented, blood pressure on hypotensive side, GVP not raised, plasma sodium 140, potassium 1.7. Any potassium like this in emerge, just what in your mind is emergence or not? Cardiac arrhythmia, you should check any cardiac arrhythmia or any respiratory muscle paralysis or quadriplegia, and should treat by KCl first. Urine chloride is okay, bicarb alkalosis. Now, blood pressure low, and the potassium low, and alkalosis. Low or normal blood pressure, hypokalemia, and metabolic alkalosis. Now, we have severe hypokalemia, low blood pressure, volume depletion, metabolic acidosis. Hypokalemia, low blood pressure or normal blood pressure, metabolic alkalosis. We have big differential diagnosis for that. If we have metabolic alkalosis, just we'll go to assess effective arterial blood volume. Here when the blood pressure, if it's low or high. If it's low, just please, if you have found your blood pressure low or normal, just check urine chloride. Urine chloride is low, your patient is vomiting, even if she denied. If it's persistent or always high, just Barter syndrome or Gentleman syndrome, acquired Barter or Gentleman syndrome. If it's intermittent high-low, this is with diuretic. If I found my blood pressure is high, this is last differential diagnosis we'll discuss later. We'll concentrate now in this arm. Factors increase potassium secretion. What is a factor increase your potassium, or K factor for potassium secretion or potassium loss? Aldosterone, what is the mechanism of this hormone? This hormone, this patient already with hypovolemia should activate aldosterone. Aldosterone will increase sodium reabsorption and the potassium secretion via inactive channel or distal collecting duct. You'll increase like inactive activity for sodium reabsorption. Sodium and the second mechanism, high or more sodium delivery to aldosterone sensitive distal nephron. When we have sodium delivery to aldosterone sensitive distal nephron, this is a mechanism when I'm giving any patient with hyperkalemia normal saline will increase sodium delivery to aldosterone sensitive distal nephron. And this will increase sodium reabsorption via inactive channel on the collecting duct, and make your tubular lumen more negative. When I am taking sodium from lumen tubules من الماسوره او الانبوبه بتاعت الكدني، انا باخد منها صوديوم دلوقتي، هيبقى عندي البوزيتيف كله دخل الخليه، اليومن دلوقتي هيصبح نيجاتيف. النيجاتيف دي make more tubular lumen more negative. Sorry. And this drive more potassium secretion. You will take potassium from intracellular to just electroneutrality of tubular lumen 2 because it's negative, and inside the cell now more positive, potassium will go out of the cell. This is the mechanism. When you are given normal saline, you will correct hyperkalemia or you can make hypokalemia. Alkaline tubular pH, same mechanism, will just enhance potassium secretion from inside cells. How loop and thiazide diuretic cause hypokalemia? How loop and thiazide diuretic cause hypokalemia? This is a common question for you. By block potassium chloride reabsorption from their channel, a loop and this convoluted tubules. We have loop diuretic here channel on السيك ascending lymph loop of Henle. Sodium potassium 2 chloride co-transporter channel. And thiazide diuretic in distal convoluted tubules, sodium potassium co-transporter channel. When I am blocking this both two channels, block reabsorption sodium chloride from these channels and increase sodium chloride delivery to collecting convoluted tubules and increase aldosterone by decreasing. And this is one mechanism. Like by block this lead to increase this and lead to more sodium reabsorption and potassium secretion via wrong channel. Other mechanism increase aldosterone by decrease effective arterial blood volume. This is the first mechanism. Blockade channels will increase sodium delivery to collecting that, lead to more sodium reabsorption and more potassium secretion. Second mechanism for loop or thiazide diuretic, increase aldosterone by decreasing effective arterial blood volume and lead to more sodium reabsorption and potassium secretion. Aldosterone, what is the mechanism? Is open more ENaC. We give ENaC channel from inside the cells to and put here in the luminal surface of the tubules and activate this channel for more sodium reabsorption, and this lead to because the sodium is positive charge, we will keep the tubular lumen is negative, and this lead to potassium secretion from inside the cells to tubular lumen and lead to kaliuresis or hypokalemia. Will end by hypokalemia. Why hypokalemia with vomiting? This is a common question too. If I have one patient who is vomiting, what is the mechanism of hypokalemia? When I am vomiting, I am losing the common acid in our stomach, HCl. This will increase your plasma bicarb. The kidney tubules will fill your plasma as with high bicarb. What will do? Loss extra bicarb in our urine. When I am losing this bicarb in my urine, I will lose with this bicarb. I will take some sodium, some potassium, some water, and this lead to hyponatremia, hypokalemia, and volume depleted. This is the mechanism. I hope it's clear. Just differential diagnosis: hypokalemia, metabolic alkalosis, and low blood pressure or normal. Just we have diuretic, vomiting, gentleman, just from urine light, sodium, potassium, chloride. If we have diuretic, all will be high. Sodium high, potassium high, and the chloride high. If I have vomiting, just sodium will be high, and the potassium will be high, and the chloride will be low. And if we have gentleman or Barter, all will be high too, like diuretic-like syndrome. Barter equal 24-hour Lasix intake, diuretic. Gentleman equal 24-hour hydrochlorothiazide intake, like diuretic electrolytes in the urine. Back to our young women. Sodium 60 is high, potassium is 80 is high, chloride 110 also high. This is a serraceous for vomiting with bicarbonate. Driving excretion of sodium and potassium is the mechanism of bicarb. Any bicarb loss will take sodium and potassium and lead to hypokalemia. Because this is our patient with metabolic alkalosis and vomiting loss of sodium chloride will increase bicarb, extra bicarb. Our kidney tubules are sensitive to this extra bicarb or loss bicarb, and bicarb loss will take sodium and potassium. And this our diagnosis for our patient is bulimia nervosa. Bulimia nervosa, okay? Next case, 31 years old man, 1 week, headache, lethargy, no history of hypertension, no vomiting, diarrhea, or diuretic. Headache, lethargy, and no history of hypertension, no vomiting, diarrhea, vomiting. This patient presented by agitated. When I examine her in emergency, agitated, blood pressure 200/100, heart rate is 90, GBP is not raised, 3 centimeters above sternal angle. Mind generalized muscle weakness. I have now 31, young. And this hypertension, you should check what is the secondary cause of this hypertension. Just came by 31, male, headache, discharge, and no history of hypertension, no vomiting, no diarrhea, no diuretic. And when I examined my patient in emerge, I found patient agitated, blood pressure is too high, maybe hypertension, encephalopathy, maybe others. And mild generalized muscle weakness is potassium 2.5. Now, what you will do? Emergency or not? Cardiac arrhythmia or not? Muscle weakness or not? Start KCL first infusion. Emergency or not, as we mentioned, ECG finding, prominent UAF, or arrhythmia. Sometimes you will see ventricular tachycardia or other ventricular arrhythmia, or ventricular premature beats, ventricular tachycardia, ventricular fibrillation, or pulses electric activity, or asystole at the end, or cardiac arrest. This potassium shift or no, we decide urine potassium to creatinine ratio. If it's less than 2 with potassium shift, if it's more than 2 is potassium loss. Our urine potassium 40 to 10, around 4. And with loss, potassium loss, not shift now. And bicarb is 36 is alkalosis. Hypertension, loss from urine potassium to creatinine ratio, and hypertension and metabolic alkalosis. Okay. Our potassium secretion. You know, the principal cells is the main key regulator for potassium secretion in the collecting duct. Well, this is the most important proximal part of collecting duct is aldosterone sensitive distal nephron. Aldosterone sensitive distal nephron in the collecting duct. With the principal cells, we have now, we need to lose potassium, we need ileum, this is the kidney tubules, and this our cells, we need ileum to be negative and hole on the wall. عندنا الفتحة دي اسمها الرون كي channel, renal outer medullary potassium channel, renal outer medullary potassium channel. Potassium will come from positive charge here through this hole, room K, to lumen, because the lumen is negative because sodium reabsorption here via inactive channel. Sodium reabsorption with electrogenic. Wow, this inactive channel, this is the second hole here. I reabsorb sodium here if I have sodium delivery to aldosterone sensitive distal nephron. The sodium will go through his hole, inactive channel. Epithelial sodium channel, epithelial sodium channel, ENaC. Sodium will go from lumen to cells. More positive, more negative. Potassium inside the cell is high, you know. Sodium here around the lumen around 140, 150 is high, positive. We'll go to inside the cells because only 4 or 5 here. And the potassium here, 140, 150 against the potassium outside the cell. Now, sodium reabsorbed here will keep more negative here, and already we have sodium here now positive, and the potassium is also high positive. Charge will go will less because his negative, potassium will go outside. This is the mechanism. Our any patient with hypokalemia, what is the mechanism when you are given normal saline or you are given diuretic? This is the mechanism of this picture. I hope this is clear. Again, we have aldosterone sensitive distal nephron. This is the kidney tubules and collecting duct, and this we have this principal cells. This is the main key regulator of this renal cells or body cells, whatever. This is the principal cells, the main key regulator of potassium. I have here in the lumen potassium is high, extracellular more than 150 or 140, and inside the cells is low sodium around 5 or 4. And the potassium against this, the potassium intracellular more than 150, and outside the cells around 5. We have here sodium reabsorption via this inactive channel, lead to keep lumen here negative and here more positive, and potassium will be secreted to do electroneutrality between tubular cells and tubular lumen and the tubular cells. I hope that picture is clear. This will clarify for you the mechanism of this ENaC and RONK channel. Okay, as we discussed, hypokalemia, this patient, as we discussed before, is more negative, more sodium absorption, and this will excrete the potassium to electroneutrality. Aldosterone, just what is the mechanism of aldosterone? Aldosterone came from where? Either abnormal or either from effective arterial blood volume depletion. Our patient is depleted. Aldosterone will come to active mainly on these principal cells. And what is final mechanism of he will activate this channel? Either bring the channel from inside the cells to insert it in the luminal tubules or activate this already channel here, inactive channel to more sodium reabsorption. More open ENaC, either my patient volume depleted will activate aldosterone, or other I have primary active ENaC. And we have three category for that. Either we have problem with primary hyperaldo, hyperrenin, or I have cortisol work like aldosterone or as aldosterone, and we have mutation in the ENaC channel, this Liddle syndrome. We have three differential diagnosis now for this category. This primary active ENaC, primary means either hyperaldo, hyperrenin. This is the first category. Second category, we have problem with cortisol is high and working like aldosterone. And the third category, we have mutation in this ENaC channel. More open ENaC. We have ENaC channel now more open. Just we need to check GVB, jugular venous pressure, blood pressure. Low, both GVB and blood pressure is low effective arterial blood pressure, and this increase aldosterone will activate ENaC and more sodium absorption, more potassium excretion, hypokalemia. If it's GVB and the blood pressure is high, both is high, this is primary active ENaC, and we'll come to differentiate this in next case. We have now more open ENaC, GVB is low, blood pressure is low, both low. Either my patient is vomiting, patient on diuretic, Barter, gentleman. Oh, this thick ascending limb of lobe of Henle. This is a nice picture to show you those 5 types of Barter, and each by his channel. We have the first one, thick ascending limb here, and this is the tubular cell, and this is lumen of the tubules. In the thick ascending limb, lobe of Henle, we have sodium, potassium 2 chloride channel here, the first channel or first type of Barter syndrome. We have the second type of this channel, chloride channel. This is the second type of Barter syndrome. And the third channel on the parting channel, this is the third type. And we have sodium, potassium, ATPase channel. We have this is the fourth type. We have now 4 types for Barter. The first type, sodium potassium 2 chloride co-transporter. Second type, work on this chloride channel. Third type, work on parting channel. And the fourth type, work in this channel, 3 sodium potassium ATPase channel. Fifth type. Just before we go to the fifth type, I need you to know what is happening here in thick ascending lobe of Henle. We have sodium potassium 2 chloride channel co-transporter here. We have this 2 chloride will be taken with 1 sodium, with 1 potassium, and this should be happening because here more positive and the potassium will be recycled, more positive here and the lumen more negative, potassium will go through room K to do electroneutrality. Room K, renal outer medullary potassium channel. And we have this chloride channel for high, because chloride here is already reabsorbed and with high negativity, also will go out to our body cells. And this potassium ATPase channel, and this Barton already just disactivate this channel. And sodium potassium ATPase will reabsorb or return back to our body cells to potassium and will reabsorb to our intravascular sodium. This from blood vessels wall to tubular cell to tubular lumen at the end. This from the blood vessels like this to the room K at the end. And this sodium reabsorption will go to intravascular to replete our volume depletion. We have now this 4 channel, number 1, number 2, number 3, number 4, number 4. This is sodium potassium 2 chloride is 1 channel, and the chloride channel is the second one, and sodium ATPase and room K. This is the 4 channel now. When sodium recycling, potassium recycling here, and we'll go to the lumen will become more positive, and this will activate what? Your calcium, magnesium, and sodium reabsorption. Meaning, just don't forget this calcium reabsorption from high positivity here in the thick ascending limb from in between cells. And this calcium reabsorption will stimulate calcium sensitive receptors. This calcium sensitive receptor will block this. Okay, we have now 5 types of Barter channels. Either this loss function of this sodium potassium 2 chloride channel, loss of function of chloride channel, loss of function of sodium potassium 2 chloride channel, and loss function of ROMK channels, or activate this calcium sensing. This will block this. We have loss, activation. This is the 5 types of Barter. 5 types of Barter. Loss of function on this channel, this first type. Loss of function chloride channel, second type. Loss of function on this sodium potassium ATPase on the basolateral membrane, this is the third type. Loss of function of ROMK, this is the fourth type. Activation of this calcium sensing receptor channels is the 5th type. Now we have these 5 types of Barter. Barter syndrome equal 24 hours Lasix intake. Gentleman syndrome equal 24 hours hydrochloroside intake. Gentleman versus Barter, how you can differentiate? Gentleman already commonly with hypomagnesemia and hypocalciuria. Gentleman, hypomagnesemia, hypocalciuria. Hypomagnesemia, hypocalciuria. We have just to mention acquired Barter, like in hypercalcemia, aminoglycoside, patient with gentamicin, streptomycin, patient with cisplatin will give you acquired Barter syndrome. Cationic proteins from multiple myeloma, this will activate what channel? This channel, calcium sensing channel, will block this potassium, ROMK, and this cationic proteins from multiple myeloma, all this will stimulate the calcium sensing receptors. Now, we have more open ENaC. GVB low, blood pressure is low. Just please check your chloride to help you to differentiate what is your case. Blood pressure low, GVB is low, urine chloride is low for vomiting or remove diuretics. If it's persistence high, urine chloride, Barter or Gentleman syndrome. Urine chloride low, less than 20 millimole per liter. If it's low, with low GVB, low blood pressure, vomiting diuretic. If it's high, persistence or intermittent. Persistance, Barter Gentleman syndrome, intermittent diuretic. And now we reach to this, hypokalemia, urine potassium 2 chloride more than 2, metabolic acid-based disturbance, we have metabolic alkalosis, volume status patient low or normal blood pressure, urine chloride low, vomiting, remote diuretic, persistence high, Barter Gentleman or acquired Barter Gentleman syndrome, intermittent high, low, this diuretic. Okay, we'll go now to the second part of metabolic alkalosis hypertension. This is nice picture why you should correct hypomagnesemia before hypokalemia. From this ROMK, renal outer medullary potassium channel is already present, and thick ascending limb under the sodium potassium 2 chloride channel. Renal outer medullary potassium channel, we have here intracellular inside the cells. On the tip of the channel او البوابه بتاعت الانبوبه دي او الفتحه دي موجود هنا بوتاسيوم على المدخل بتاع البوابه دي. البوتاسيوم ده positive charge. This positive charge will reject potassium secretion and loss in urine. This is our urine or urine tubules. These are our cells. This is renal outer medullary on renal tubular cells, and we have magnesium as a guard حارس هنا على الانبوبه ديت مانع البوتاسيوم يجي هنا بوزيتيف تشارج مع بوزيتيف تشارج طبعا ما هينفع يعدي. لو عندي hypomagnesemia, this will help to escape the potassium to urine and lead to more calciuresis and hypokalemia. So you should replace this magnesium first before you replace your potassium. And this already discussed. More open ENaC, as we discussed, either low effective arterial blood volume will secrete aldosterone. Aldosterone will stimulate ENaC. ENaC will reabsorb sodium and excrete more potassium. And the second step, primary active ENaC. We'll go to primary active ENaC. This is the most important now in our topic. Patient with primary hyperaldo or hyperrenin renin secretion. Renin will stimulate, at the end of his cascade, will stimulate more aldosterone. Aldosterone will bind by his receptor to his little principal cells of collecting blood, and with via, and will do just his complex here inside the cells, and stimulate this serum glucocorticoid kinase 1. Serum glucocorticoid kinase 1. And this will do phosphorylation and inhibition of this NID4-2 protein. This NID4-2 protein responsible for degradation or withdrawing this ENaC channel to lysosome and degradation or destruction. And this lead to this by this hyperrenin and hyperaldosterone, and by this enzyme inhibit this. B will be inhibited, lead to more ENaC here, and more sodium reabsorption and more potassium secretion and hypokalemia. I hope this is the first abnormality for this primary active ENaC. Primary, just thinking maybe genetic. Just put in your mind genetic or something abnormal. This primary, not related to a patient. We have the first problem, renin, high aldosterone. High renin, high aldosterone, this will join with aldosterone here, will join with his receptors and activate the complex here. This complex will stimulate serum glucocorticoid kinase 1. This is responsible for phosphorylation and inhibition. This NID4-2. This NID4-2 responsible for destruction of this ENaC. We know this inhibited already. We have now abnormally high ENaC channel, more sodium reabsorption and more potassium secretion. As we said, this is already discussed. If you would like to read the mechanism again. Primary active ENaC. The first problem now, high aldo with hyperrenin. If you have high aldosterone and high renin, you should think any patient with hypertension, hypokalemia, metabolic alkalosis, please send spot blood sample for serum aldosterone and renin. If I have found high aldo, high renin, just put in your mind this patient differential diagnosis, renal atherosclerosis, malignant hypertension, renin secreting tumor. Primary hyperaldo and with lower normal renin, this patient with adrenal adenoma or bilateral adrenal hyperplasia, and this rare syndrome, glucocorticoid remediable aldosteronism. This is our differential diagnosis. First problem in our patient with hypokalemia, hypertension, metabolic alkalosis. And this is our diagram. Hypokalemia, urine potassium to create ratio more than 2, acid-base disturbance, metabolic alkalosis, hypertension will go to primary mineralocorticoid effect, differential diagnosis. This is the first differential diagnosis. Okay, and this diagram from Brenner again. As we mentioned, we reach here to metabolic alkalosis with high blood pressure. We'll check aldosterone. If it's high, renin. If it's high, this was renal stenosis, renin secreting tumor, malignant hypertension. If it's low, primary hyperaldosteronism, Cohen's syndrome, most common. And if the aldosterone is low and the cortisone is low, this was later licorice, and we'll discuss this. If the aldosterone is low and the cortisone is high, this is Cushing syndrome. I hope this also algorithm is clear. Effect of mineralocorticoid excess. Just activate sodium potassium ATPase, more potassium loss. Activate TRON-K, more potassium loss. Activate more ENaC senses, sodium reabsorption, potassium loss. activate serum glucocorticoid kinase. This will inhibit a NIT2 protein, this protein responsible for catabolism of inactive channel, and this lead to more inactive and more cerebral absorption, more hypokalemia. And this serum glucocorticoid kinase 1 phosphorylate inhibition, just do phosphorylation and inhibition of NIT4, decrease ENaC endocytosis and the catabolism, lead to increase more ENaC, more soluble absorption, more potassium secretion. I hope this clear, and this clear, and this ROMK, and this sodium potassium ATPase, all this if activated lead to high potassium secretion and hypokalemia. Okay, second mechanism. Cortisol is not aldo. We'll discuss the issue for what is the benefit of 11-beta-hydroxysteroid dehydrogenase. We have cortisol here. The cortisol will be break down by this 11-beta-hydroxysteroid dehydrogenase. 2. Cortisol will be break down to cortisol will be inactive. And this will prevent this cortisol to bind this aldosterone receptors and activate the serum glucocorticoids. This will inhibit NIT2, will keep ENaC here active, not destructive. Here, the issue here, 11-beta-hydroxysteroid dehydrogenase. If it's absent or lack or overwhelm, and we'll see what will be happening. Here, either we'll find this 11-beta-hydroxysteroid lack in apparent mineralocorticoids. If it's inhibitor, like racemic acid licorice, this body present licorice already. If it's overwhelming from cortisol overproduction, ACTH production tumor. Here, what will be happening if my enzyme is lack or inhibited or overwhelming by high cortisol? Cortisol will act now like aldosterone. Cortisol here will join with aldosterone receptor, stimulate this complex inside the cells, lead to activation of this serum glucocorticoid kinase 1, and this will phosphorylate and inhibit this NIT2 proteins, lead to, well, now this tubule will not be destructive because NIT2 already inhibited, and lead to this continues to be more active, more soluble reabsorption, more potassium secretion. I hope that clear now. We have 11-beta-hydroxysteroid already either in lack or inhibited or overwhelming. Okay. Again, cortisol working now like aldosterone, will bind with the aldosterone receptor, activate this complex, will lead to serum glucocorticoid 1 stimulation. This will phosphorylate and inhibit this NIT2 responsible to start this ENaC channel. Now ENaC will be more active, more sodium reabsorption, more potassium secretion, more hypokalemia. Now the second, cortisol acting now as aldosterone. Cortisol acting now as aldosterone because already we have this lack or inhibited or overwhelming 11-beta-hydroxysteroid. Welcome now. What is the third abnormality for high mineralocorticoid excess? Abnormal ENaC. We have genetic problem in the ENaC channel, and this will be named as Liddle syndrome. This mutation already happened in the ENaC channel, interfere with the effect of NIT4 to cause lysosomal degradation of this ENaC channel. Now we have this mutation in the ENaC channels, just doing this inhibition of this NIT2, and no more destruction for ENaC channel, more soluble reabsorption and potassium secretion. Increased potassium secretion in the aldosterone system, genetic abnormalities is ENaC Liddle syndrome, this autosomal dominant. Don't forget autosomal dominant. ENaC here lacks the appropriate intracellular tails that normally makes it susceptible to endocytosis. Now we have lack of this intracellular tail that normally make it susceptible susceptible to endocytosis. Now هناك, because this absence of hair tail will not be able to come to endocytosis and to be degraded by need for to protein. Here we have this absence of tail of this inactive channel. This will affect the endocytosis. This ENaC to be distracted by lysosome by this help of this need for two, just to help for this endocytosis to be distracted. Okay. Liddle syndrome, as we mentioned, is a mutation already of ENaC interfere with the effect of need for two to cause lysosomal degradation of ENaC channel. And this mutation in genes PXYY motif. Now we have this primary active ENaC, we have high aldo, either high aldo with primary hyperrenin or high aldo with primary only hyperaldo as adenoma hyperplasia, and we have cortisol act as aldo with problem in the leaving hydroxysteroid dehydrogenase 2, and already we have mutation in the ENaC channel. This was Liddle syndrome. Best if high renin, high aldo for differential diagnosis. This primary hyperrenin, as we differentiate renal artery stenosis, malignant hypertension, renal secreting tumor. If only we have hyperaldo and low renin, this was Cohen syndrome, and this low both renin, both aldo, this was cortisol act as aldo or Liddle syndrome mutation in our ENaC channel genetic mutation. And these others summarized for that. We have aldosterone and renin, high renin secreting tumor, renal artery stenosis, malignant hypertension. If it's high aldo and low renin with this adrenal adenoma, bilateral adrenal hyperplasia, and the GRH, glucocorticoid remediable hyperaldosteronism. If it's low aldosterone, low renin, this with cortisol act as aldosterone, ectopic ACTH, genetic lack of 11-beta hydroxysteroid hydrogenase 2 and licorice or Liddle syndrome. Okay, if it's low. These are our differential diagnosis for our patient today. Either high cortisol or licorice or Liddle syndrome. Back to our case, 31 years male, 1 week headache, surgery, no headache, no history of hypertension, no vomiting, diarrhea, diuretic. He's agitated, hypertension, and mild generalized weakness with hypokalemia. Our patient is low. He's under this category, is low aldosterone, low renin, either cortisol act as aldo or Liddle syndrome. Just when we ask for more details in his history, what is his intake at home, he drink more licorice at home. And this licorice will inhibit, this number two mechanism of cortisol act like aldo. And this inhibit glycyrrhizinic acid. This is already present in licorice. This is already inhibited by this licorice. And to remind you, with cortisol, the same scenario like more activation of ENaC because it's not working now. More sodium reabsorption, more potassium secretion. Our mechanism for licorice inhibited glycyrrhizinic acid, inhibit 11-beta hydroxy. Steroids that will break down cortisol, T-cortisol, so cortisol not work. But now this is already inhibited, so cortisol will play with the aldosterone receptor, stimulates this serum glucocorticoid kinase. This will lead to phosphorylation and inhibition of need for two, more and no more destruction to ENaC. ENaC will be more active, more sodium reabsorption, and more potassium secretion. Case 8. 48 years male, hypertension, blood pressure 190/115, LVH, sodium 144, potassium 2.5, bicarb 30, creatinine 115, sodium 90, potassium 45. Male patient, hypertension, hypokalemia, alkalosis. Hypokalemia, metabolic alkalosis, and high blood pressure. We have our differential diagnosis as a primary hyperaldo. Hyperaldosis with low renin, adenoma, bilateral adrenal hyperplasia, or primary hyperaldo, hyperrenin, RAS, malignant hypertension. Okay, and this question, and we'll see what is our differential diagnosis for this. Okay, as we mentioned before, all causes of mineralocorticoid excess, all cause high blood pressure except volume depletion. Aldosterone, primary hyperaldo, as we discussed before, and the low renal suppresses adrenal adenoma or bilateral adrenal hyperplasia. If we have high hyperaldo, hyperrenin, we have differential diagnosis, renal stenosis, renal secreted tumor, malignant hypertension. Other differential diagnosis, as I mentioned before, cortisol acting like aldo and Cushing syndrome. This was ectopic ACTH secretion overwhelmed, leaving beta hydroxybutyrate. We discussed this before. I need to summarize if you like to read more. And now in our diagram, we are reaching to blood pressure for assessment. Our patient whose aldosterone is high or low, and you can read later. Our patient is renal aldosterone came. Just for differentiation, any patient you send for renin and aldosterone in your diagnosis, renin and aldosterone. In primary hyperaldo, just we have high aldo and low renin, and the RAS here with high pose, renal stenosis, and the little is low pose. High pose with renal stenosis, low pose with little syndrome, high aldo, low renin with primary. This is the most common cases. Just what I need from this slide, just to concentrate only one point. But I hope you understand all the previous slides. I just find this slide some interesting point. I present it just to be easy for us to catch the most common, the commonest common. If we have high aldo low, this with cones. High renal stenosis, you should rule out renal stenosis by renal Doppler, CT angio, MRA, or even catheter angiography. This is a 3 diagnosis for renal stenosis. If low aldo low renin, you should rule out Liddle syndrome, licorice, and other causes, as we discussed before. And it's also the same, hypokalemia with metabolic alkalosis, we already discussed this. Now, case number 9, just to enumerate this case rapidly, 28 years woman with worsening leg weakness, no other complaint, no medication, past medical history, none. Blood pressure 114, legs is paralyzed. Her legs are paralyzed. ECG with prominent U wave and prolonged QT interval. 28, female, paralysis. Blood pressure is okay, is low normal, and with bicarb is 12 acidosis, and this 1.8 potassium, creatinine, urea, sodium chloride. High chloride acidosis here, bicarb 12, and the potassium 1.8, and the pH 7.2. I think is metabolic acidosis with hypokalemia, and the blood pressure is normal or low, and they have urine potassium 2 creatinine, and we'll see, and if urine potassium is 9, just divide this by 2.8, and this we'll see. I think if it's around more than 2, urine potassium, you'll divide this urine potassium 9 by 8, around 3.2. This patient now, just to be summarized, just to enumeration all for you, just hypokalemia, metabolic acidosis, and urine potassium creat more than 2. This patient was hypercholoremic, chloride here is high, hypercholoremic, metabolic acidosis. This patient will go with diarrhea versus RTA versus below sniffing, as we discussed before. What is here? Ammonium secretion, as we told before, measured minus calculated, will give you the ammonium. You know, normal ammonium secretion around 40 daily secretion. This 40, and here ammonium secretion 23. Less than 40, this means your patient with RTA. If the ammonium secretion is high, more than 40, this is RTA. This is our patient diagnosed as RTA, okay? Just to remind you, just another case, 20 years, progressive weakness for quadriplegia, no vomiting, diarrhea, or diuretic, blood pressure 116, flaccid paralysis for forelimb with flaccid paralysis, and here potassium, hypokalemia, alkalosis, chloride is okay, and this also with alkalemia. Now we have metabolic alkalosis, hypokalemia, flaccid paralysis. We'll come to urine potassium to create ratio more than 2. Hypokalemia, metabolic alkalosis with normal blood pressure. Blood pressure, as we mentioned here, 116/72 with flaccid paralysis. Don't forget the issue for any hypokalemia, emergence or not emergency. Just we can proceed for other. Just I enumerate these interesting cases for you. Okay, this patient hypokalemia, metabolic alkalosis with urine K2 create more than 2.9. This urinary loss. With this metabolic alkalosis, hypokalemia, normal blood pressure will go to urine chloride, assess urine chloride around here 90, urine chloride where is around 80. Urine chloride here is 80. More than 10 or 20, this is with hypochloremia. This either will go to differential diagnosis, either vomiting or Barter or Gentleman syndrome or diuretic. This patient now 20 years, progressive weakness, quadriplegia, blood pressure little bit normal or hypotension, normal blood pressure, with flaccid paralysis, hypokalemia, and alkalosis. Now I diagnose my patient. This patient hypokalemia, okay. This is first step. Second step, urine creatinine ratio more than 2, renal loss. Acid base, metabolic alkalosis. Blood pressure, normal blood pressure. Urine chloride is high. My differential diagnosis, he should be urine chloride is high. Maybe this patient who is diuretic, is vomiting or diarrhea, vomiting or Gentleman or Barter or diuretic. Serum magnesium, please, and hypomagnesemia. Don't forget to treat hypomagnesemia as we discussed before. This case may be Gentleman or Barter syndrome. We'll check calcium to creatine ratio. If it's low, because our Gentleman characterized by what? Hypomagnesemia, and maybe also Barter syndrome with hypomagnesemia. But the most sensitive test, calcium to creatine ratio. If it's low, this was Gentleman syndrome. Our patient is Gentleman syndrome. And next case, 35 years male, healthy, and blood pressure hypertension, 250 over 140, plasma potassium 2.9, bicarbonate alkalotic, urine potassium 2 create, I think more than 2. 35 young male, hypertension, hypokalemia, alkalosis, and I have now urine creatinine ratio more than 2. Second step, acid-base disturbance alkalosis. Volume assessment hypertension will come. Hypokalemia, no reason for shift, and his urine potassium more than 2, around 6. With metabolic alkalosis, with hypertension, mineralocorticoid, you need to exclude the aldosterone and renin. You should be checked that. Aldosterone is high, renin is high. I think renin is okay. Aldosterone is high. Aldosterone to ratio 417, normal more than around 140. And this patient will receive DKSL, amlodipine, doxazocine, labetalol. After 2 liters of normal saline, aldosterone will increased 1,386. CT scan showed adenoma in his left side, left adrenal vein, aldosterone, cortisol level lateralized to the left. This is a test already, and just showing lateralization to the left adrenal gland. Post laparoscopic left adrenal lectomy. Already the patient doing surgery. Blood pressure improved, but still need 2 medication for control. But the plasma potassium is controlled. With adrenal adenoma, primary hyperaldosteronism with low cortisol, low renin. Just this patient is a nice case to diagnose this primary hyperaldo and low renin. This is a Crohn syndrome with adrenal adenoma. Increase potassium secretion in aldosterone sensitive distal nephron, amphotericin. Don't forget amphotericin. Patient with amphotericin, leaky distal nephron. This causes increased membrane permeability and making some potassium loss and enhance potassium secretion. Also rule out distal artery in this patient. Don't forget this, just to remind you. Excessive potassium loss, either urinary increased flows or aldosterone sensitive distal nephron, or increased potassium secretion in ECD nephron. This combined abnormality will be happening with potassium secretion, especially in osmotic diuresis and diuretic distal artery vomiting genetic syndrome. Just this table also, just I need to look for some point, Barter gentleman, this main sick ascending limb, Barter syndrome, and this the concluded tubule. The main channels, sodium potassium 2 chloride, and here sodium chloride co-transporter channels. And here behaves like 24 Lasix intake, and this is gentleman 24 Cyanide intake. Hypomagnesemia may be imposed, but more common with gentleman syndrome. Urinary calcium excretion increased in Barter, and you have hypercalciuria, but in gentleman hypocalciuria. Acquired Barter, as mentioned before, hypercalcemia, aminoglycosides, cisplatin, and multiple myeloma. This acquired Barter syndrome. Management, principle of therapy. I think therapy now is easy for each patient. As emergency, we treat emergency and then investigate whatever the time. The best is to keep your patient life saving. Principle of therapy, just replace the potassium upfront and making it worse, especially with shift. You should take care and diagnose your patient, identify and treat the underlying cause, go through all our discussion before and prevent in future by trying to treat the cause or control the cause. Oral potassium replacement, as I mentioned here, in our diets, just every salt substitute around 50 to 65 millimole per teaspoonful, and the potassium chloride 600 milligram equal 8 millimole, and 1,500 equal 20 millimole. Just take care, the patient will take with huge amount of water or juice, because this will do GIT ulceration and severe burning. And regards the syrup already potassium, this around 20 millimole per each 15 ml. 15 ml, 20 millimole. 15 ml, 20 millimole. Oral potassium secrete also available. Potassium citrate, 10 milliequivalent, 25 milliequivalent tablet already. As regards the IV, potassium chloride, bolus in ICU by central line, you can give 20 ml per 100 normal saline, or as preferred, we can get 40 over 1 liter up to just 40 over 1 liter is okay, and continue infusion whatever the rate you like. Dose of replacement if no shift, serum potassium fall by 0.27 millimole for each 100 millimole loss. If I have my patient with potassium loss, each 100 millimole loss will decrease your potassium by 0.27 millimole per liter. And the principle of dosing the potassium, just take care. I afraid only from rebound hyperkalemia in patient if your patient with shift as a first presentation of hypokalemia. Partially correct relatively quick safe level. You will continue to correct your patient to reach to safe level, and after that you go slowly. There is no precise way to estimate the required amount. The required amount, you know, if you need to increase 1 millimole of your potassium or more milliequivalent, you need at least maybe 100 to 200, but no precise way to estimate the required amount for potassium replacement. Need also to replace ongoing loss of your patient with diarrhea or vomiting. Please just replace also loss, don't like your hypernatremia. Just replace a loss and replace a deficit already. We have deficit and we have loss, replace both. In most of cases, just please don't forget to use KCL at the start of your management. Severe hypokalemia, mild from 3 to 3.4, we can give enough KCL, 20 milliequivalent BID for 3 days and observe your potassium daily. And if severe hyponatremia less than 2.5, we can use oral plus IV. As we mentioned before, life-threatening cardiac arrhythmia, respiratory muscle weakness, or rhabdomyolysis, we can use KCL IV as bile ICU. We can insert central line, and that we can give 10 to 20 ml per hour, then 100 ml normal saline, this is by ICU central line. Or you can go peripheral, just 40 each for each liter, and continue infusion with oral tap, and the patient can tolerate. Just please don't forget, don't put KCL with D5. D5, dextrose will increase insulin release, more potassium shifted to inside the cell. Don't give bicarb. Bicarb also will increase more shift and will deteriorate. No D5, no bicarb. Please correct your potassium first to become more than 3, then start other treatment for acidosis by bicarb. IV replacement, please dextrose. Should be dextrose free because this will increase insulin will activate ATP channel, and this will lead to more potassium secretion. treatment of underlying cause is the most important in your management after you stabilize your patient. And correct, don't forget hypomagnesemia. Hypomagnesemia, as in the figure or the slide we discussed, the mechanism of hypomagnesemia was hypokalemia. Okay, because your hypokalemia will not be corrected until hypomagnesemia is corrected. Potassium is the second main cations in our body. Dietary intake around 80 to 120 millimole per day for our summary. Our normal potassium 3.525. If it's a severe life-threatening, you should give IV. Potassium downweight has normal potassium intake and secretion around intake 80 to 120 millimole per day, and excretion around 8 to 10 millimole per day, and the urinary around 70 to 90 millimole per day. Don't forget potassium shift and differential diagnosis. With our hypokalemia, is a decrease intake, but this is not enough. You should rule out shift or loss via skin or GIT or renal. Reduce potassium intake. This low potassium intake, it can be always contribute to hypokalemia with loss or shift. Rarely the sole cause of hypokalemia from just only intake. You should check another cause. We know this is a main cation. Intracellular potassium is around 140 or 50 inside the cells, and outside the cells, as we mentioned, 3.525. And the potassium, you know, just to remind you, freely filtered by glomerulus around 700 millimole per day, and you absorb it from convoluted tubule more than 75, lopophilia more than 15, and secretion already via these principal cells and via controlled by aldosterone and principal the K cells, principal cells for aldosterone secretion, and this just the distribution in potassium reabsorption secretion to our tubules. And with our already mechanisms of potassium reabsorption secretion or sodium reabsorption secretion to our tubules, principal cells, we discussed already before. And we know this functional unit of the kidney with cortical distal nephron, aldosterone sensitive distal nephron, ASDN. Aldosterone sensitive distal nephron is the functional unit of the kidney responsible for potassium regulation. This is a principal cell. And this distal convoluted tubules with sodium chloride channels for Gentleman or sodium Gentleman syndrome, sodium chloride co-transporter. Okay, and this just other mechanism is to just show you. I discussed already this before for sodium chloride, sodium potassium 2 chloride channels with room K. We discussed this already before, and this mechanism of potassium secretion already we discussed in the previous slides. And mechanism also of potassium secretion and collecting that we discussed too. Aldosterone excreted potassium, we discussed this in details in previous slides. As an aldosterone activate the aldosterone inactive channel from inside the tubules to tubular lumen of our tubular membrane and increase more sodium reabsorption. And potassium secretion also activate the sodium ATPase on the basolateral membrane. All this by activate more sodium reabsorption, make the lumen of the tubule more negative, lead to more potassium secretion and hypokalemia. My home message: hypokalemia can be due to reduced intake, shift, or loss, GIT, skin, and urine or renal. Causes of shift: don't forget insulin, beta adrenergic agonist, bicarb is a cause of shift, or any high adrenergic surge. We discussed that in the first presentation. Urine loss of potassium happens due to increase aldosterone sensitive distal nephron, flow, and the potassium secretion lead to increase the potassium secretion and hypokalemia. Increase potassium secretion due to mineralocorticoids, excess or bicarbonaturia or hypomagnesemia, other anions like toluene and the uric acid, and can be suspected via your assessment of your volume status, acid base, and the urinary potassium to create ratio. Hypokalemia lead to serious arrhythmia and respiratory muscle weakness and metabolic alkalosis that we discussed before. You know, remember how metabolic alkalosis happens with hypokalemia. We mentioned if a patient with hypokalemia lead to more potassium secretion from intracellular and the hydrogen go to intracellular, more intracellular acidosis, more bicarb reabsorption, and this will take hydrogen from extracellular to intracellular. This make extracellular more alkalotic, and more intracellular acidosis will lead to reabsorption, cause more secretion of acidosis or ammonia from intracellular to extracellular intravascular compartment. The sensitive tubules lead to more reabsorption of bicarb and increase the alkalosis. This is the mechanism already we discussed in the first presentation. Treatment as emergency to your patient in emergency, please IV, central line or IV infusion. And if you have acid, you don't dilute in D5 water, dextrose. This will stimulate insulin more shift. Don't start with bicarb infusion or bicarb management before you treat hyperkalemia, because this also will increase your shift. And if we discuss already this differential diagnosis of mineralocorticoid excess, if you have high aldo, high renin, just please renin secrete tumor, renal stenosis, malignant hypertension, high aldo, low renin, adrenal adenoma, hyperplasia, and the GRH, glucocorticoid remediable hyperaldosteronism. If I have low aldosterone, low renin, just please don't forget licorice and cortisol act as aldosterone. In ectopic ACTH, you should check your patient for that, or genetic like alpha 11 beta hydroxysteroid hydrogenase 2, or Liddle syndrome of low, don't forget autosomal dominant disease, Liddle syndrome. And with our diagnostic approach, you can read later, just to take your history, send your lab, check your potassium, if it's less than urine potassium to create ratio, less than 2 or more than 2, and you can go slowly. If your potassium secretion less than 2 or more than 2, just acid-base disturbance. If no acid-base disturbance is shift. If less than 2 or more than 2, we can suspect diarrhea. We can discuss this diagram later. This also we can read. And don't forget this diagram. This is the most important. This is already summarized from Brenner book. I just try to modify it to be complementary for this. This is the main diagram I need you to keep in your pocket, your mind, your notes, your mobile, your laptop. This is the main topic to guide you how to search for hypokalemia, any hypokalemia less than 3.5, just urine potassium to create ratio less than 2. Second step, I'll go to acid-base disturbance. If you know this shift, if it's yes, what is your metabolic acid-base? Is either acidosis with diarrhea or alkalosis with diuretic, remote diuretic use, or other chronic wasting diarrhea. Just check this table. Otherwise, if your urine potassium to create ratio more than 2, acid-base disturbance, either acidosis or alkalosis, hypercholoremic metabolic acidosis, diarrhea, distal RTA, proximal RTA, and chronic anhydrase inhibitor. Just you can read this table of your urine potassium to create ratio with metabolic acidosis. If metabolic alkalosis, please check your effective arterial blood volume and blood pressure. If it's high, we'll go to this part of mineralocorticoid excess syndrome. And if it's low, just check urine chloride. If it's low, vomiting. If it's persistently high or always high, just Barter Channels. And if it's intermittent, high, low with diuretic, please. This is the most important message for you today. Treat the underlying cause. Don't forget correct hypomagnesemia, and we'll check your cause and treat if medication stop, and correct your hypomagnesemia, because the hypokalemia will not be corrected until hypomagnesemia is corrected. Don't mix KCL patient with hypokalemia with dextrose. This will stimulate insulin, ATPase, and more potassium secretion. Again, this message again, don't mix with D5, don't treat bicarb before potassium until potassium reach more than 4. And this is my reference if you like to read more details and to know more knowledge, and this same another reference, and this is the most important reference for this hypokalemia, and our chart from Dr. Kamel. بعتذر عن الإطالة في هذا الفيديو، لأن كان لازم نحاول نغطيه وما نطولش الفيديوهات كتير عشان الناس تكون مركزة معانا، ونسألكم الدعاء بالتوفيق والسداد، ولا تنسوا الصلاة والسلام على حبيبنا محمد صلى الله عليه وسلم، ونلقاكم بفيديو قريب إن شاء الله، وإن شاء الله نراكم على خير وصحة وعافية بإذن الله. السلام عليكم ورحمة الله وبركاته.